Our next joint community policy session is on the racial disparities of chronic diseases in kidney. I want to address that we have a very dynamic panel. But first, just by way of introduction, I'm Courtney Lang. I'm the founder and principal of Langco Partners, where we provide advocacy solutions for both patients and providers. I'm so pleased to be here with you today and thank Dr. Puckrin as well as Congresswoman Christensen for another phenomenal conference. The session will flow as follows. I am going to introduce each speaker. They will then present, and once they have presented, they will then sit down. We will take a Q&A at the end of all three presenters. Our first speaker is Dr. Michael Flessner, who is currently the Director of Inflammatory Renal Disease Program at the National Institutes for Diabetes and Digestive and Kidney Diseases. His responsibilities include the management of a diverse research portfolio. He has observed patients in Jackson, Mississippi, African American community, as well as with Latino populations in Frederick, Maryland, and his research currently is focusing on chronic kidney disease and other inflammatory renal diseases, including lupus nephritis, diabetic neuropathy, renal transplantation, and renal fibrosis. His presentation today is Racial Disparities in Chronic Kidney Disease, the role of the National Institute of Health in fostering innovative research. With that, please join me in welcoming Dr. Flessner.
Well, thank you, Courtney, and thank you to the organizers for asking me to present at this forum. Basically, the NIH mission is science in the pursuit of fundamental knowledge about the nature and behavior of living systems. And of course, the application of that knowledge to extend healthy life and reduce the burdens of illness and disability. So there's 27 institutes and centers. I have NIDDK as the Center for Chronic Kidney Disease in red, but there are other institutes labeled in orange that we collaborate with or who are actually carrying out studies which affect the study of chronic kidney disease. So the NIDDK research mission is to support and conduct research to combat diabetes and other endocrine and metabolic diseases, liver and other digestive diseases, nutritional disorders, obesity, and kidney, urologic, and hematologic diseases. All of these diseases are chronic. They are very common, they are consequential, as I hope to show you today, and very costly. So I'm going to start off, this is the outline of my talk, and the first thing we're going to do is try to define the program in the global sense as well as for minorities who basically, you'll see, actually suffer a great deal more than, for example, Caucasians. So this, you can see that from that arrow between 1990 and 2007, all CKD has risen significantly, and the lower GFR has actually risen as well. The lower GFR connotes a real danger sign because these people often go into renal failure, and as you'll see in a few minutes, it costs the country a great deal. So the mortality rates for all chronic kidney disease are significantly greater, and hospitalization rates are greater. So this one chronic disease puts people much more at risk for mortality and for hospitalization. And although the people that basically they make up about 14% of the population, the costs are enormous, and if they have congestive heart failure as well as chronic kidney disease, the proportion on the lower is even worse. So you can see from this that, and I've pointed out, African Americans and Native Americans have a much higher odds ratio of a chronic kidney disease diagnosis. And here, this is the unadjusted rates for acute kidney injury. Now, acute kidney injury is when people drop their blood pressure because of an accident or because of a severe operation or a severe infection, and they actually result in renal failure or partial renal failure. But you can see that African Americans have a much higher rate than Caucasians. And the number of dialysis patients, the prevalent dialysis patients, keeps rising each year. And I just want to point out that the 5-year survival of these patients, and this is over here, the hemodialysis is the one on the left here. Basically, this survival, 5-year survival, is actually just above that of lung and liver cancer, but below prostate, colon, and breast cancer. So you have a better chance of surviving 5 years with prostate, colon, or breast cancer than you do with kidney disease and end-stage renal disease. The cost of Medicare, and this is just of Medicare patients, actually is enormous. So the percentage of end-stage patients is only about 1.4%, a very small minority, but they're actually responsible for 7.2% of all Medicare spending. So obviously what we'd like to do is slow down or stop the progression of chronic kidney disease before it gets to end-stage renal disease and these patients need dialysis. This shows the location of new end-stage patients. And what you'll notice, it used to be 10 years ago, this was very heavy in the lower part of the United States. But now you'll notice that it is very dark and very high rates in the places in California and Texas where there's a heavy Hispanic population. And this just shows the adjusted incident rates of end-stage renal disease for young African Americans, 20 to 49, and older African Americans. And what you see, the white population is down here. African Americans are significantly higher than the white population. And indeed, the Hispanic population is significantly above the white population when they get older. The counts of non-Hispanic population obviously are significantly greater than the Hispanic population, but for the adjusted rates of end-stage renal disease, the Hispanic rate is far above that of all other, everyone else in the population. So one of the things we need to do at NIH and actually in this country is to really transform medical research in the 21st century. And so instead of just treating disease when symptoms appear and normal function is lost, and actually kidney disease, chronic kidney disease, you don't feel any symptoms until you've lost 90% of your kidney function and you have to go on dialysis. So we'd like to intervene before, intervene before symptoms appear. And so we'd like to actually intervene in childhood perhaps, or in patients when they're quite young, and actually they don't show any particular symptoms or other types of manifestations of the disease. And so we didn't understand at the time molecular and cellular events that lead to the disease. Now we do understand more and more every year the preclinical molecular events. And we know that this is very expensive in financial and disability costs, but we'd like to actually affect this. If we can just decrease the number of people getting to end-stage renal disease and develop new treatments for chronic kidney disease, then we can decrease the cost to the US and to our population as a whole. So I just want to mention briefly the Jackson Heart Study. I was connected with the Jackson Heart Study for several years when I was down in Mississippi. and also H. Saul, which is the Hispanic study. And this is a paper that we put out in 2007, but it shows the prevalence of CKD in the Jackson Heart Study. So men are in black, women are in white, and you can see overall it's about 20% of this population has chronic kidney disease, but when you get above age 60, it jumps up to above 30%. What was fascinating is that there were questions within the Jackson Heart Study, and it showed that most of the people, most of this 20% overall, were not aware of their disease. So again, it's a silent disease, and this is a real problem not only in the Jackson Heart Study, listed in the black bars, but also in NHANES, which is, of course, the population that CDC studies. And this is just a prevalence of CKD in Hispanic, Latinos, and non-Hispanic whites and by gender. And here's women and men. And what you can see is CKD, and the blue is the Hispanics, the green is the non-Hispanic black, and then the is white. And what you can see is both Hispanics and blacks have a significant higher prevalence in both men and women. So let's just talk briefly about the chronic renal insufficiency cohort. This has been going on for about 10 years, and the CKID, this is chronic kidney disease in the children cohort. They've both been going on for about 10 years and continue actually to be studied. And so the CRIC study is a landmark study of causes and consequences of chronic kidney disease. And so we enrolled 5,500 Americans at 13 medical centers and followed up for 13 years. And so roughly there were 4,000 participants between 2003 and 2008. Hispanic population was 12.6%, African Americans were 42.1%, diabetic patients were 48%. And as you can see, there's a distribution of the age range. The Hispanic chronic renal insufficiency cohort is a prospective observational study of individuals with mild to moderate CKD sponsored by the NIDDK. And basically, we want to try to determine predictors of progression of kidney disease and subclinical cardiovascular disease in Hispanics with chronic kidney disease. And we want to compare the rates in Hispanics with CKD due to those in non-Hispanic whites and blacks. And so one of the things we're measuring is the rate of clearance in the kidney, the eGFR, blood pressure, degrees of inflammation, mineral metabolism, and medications. And the outcomes, we want to actually determine how many go on to end-stage renal disease, develop cardiovascular disease, and what is their functional status. And of course, we have different study populations that I've already mentioned. Interestingly, what has been shown is that Hispanics actually, in this particular cohort, have a significantly higher rate of end-stage renal disease or a 50% decline in their kidney function than even African Americans. And then, of course, both of these minority groups are much higher rate than Caucasians. So what about the CKID, the children's study? And this is roughly about 550 children who have been followed a little over 10 years. And I just want to point out the differences, whereas the average difference at baseline for CRIC, the chronic renal insufficiency in adults, was 58 years. This is 11 years. The history of hypertension, less than half of them had hypertension, whereas 86% had hypertension here. There was a history of MI. Obviously, kids usually don't develop this, but 22% actually had an MI. And the prevalence of obesity, 24%, still significant, but the 55% had a BMI of greater than 30, and then left ventricular hypertrophy much greater. And so what we'd like to do is study these kids develop early markers of disease in these kids so that we can prevent some of this progression that you're seeing at baseline in the adult study. So one of the things one of the challenges is that because these diseases, chronic kidney disease, is totally asymptomatic, we have to educate people. And so the National Kidney Disease Education Project, and I'm just going to display a couple of slides. If you just Google NKDEP, you can find just a wealth of information and downloadable free information. But how do your kidneys work? Well, you've got two kidneys. Basically, it keeps the body's chemical balance and controls the blood pressure, filters waste, and gets rid of excess water. And chronic kidney disease means that the kidneys are damaged. This is sort of at a 5th to 8th grade level, but it has, I think, had a definite effect. We also have questions for your healthcare provider. So if you say, hey, maybe I have chronic kidney disease, you can take this list of questions into your healthcare provider and challenge your healthcare provider with these overall questions. So one of the things we'd like to do is not wait till people actually develop the need for dialysis, go to end-stage renal disease. We'd like to develop biomarkers that help us determine who might go to end-stage renal disease. And so obviously African Americans have a very high rate of incidence. And so one of the things, and there's a tremendous lifetime, there's actually, it's almost 4 times the ratio of blacks to white as far as the risk for end-stage renal disease. And what has been discovered in some of the NIDDK efforts is something, it's a gene attached to the APOL1 marker, and what it's due to, when the Africans were brought over to this country 100 years ago, basically some of them had evolved a resistance for African sleeping sickness, which is due to the tsetse fly. And so because of that, they were resistant to that, but this gene actually, if they have 2 copies of this gene, and only about 12% of, it's a large percentage of African Americans have 2 copies, this puts them at a 25-fold increase of developing FSGS, which is a chronic kidney disease that eventually will wind up with needing dialysis, or a hypertensive kidney disease, a 5-fold increase here. So this is an early genetic marker that we can actually test for. So this points out the fact that APOL1, this is a proportion free of events. APOL1 is way up here, whereas basically somebody without any events, a European American, will have almost no events, whereas an APOL1 non-risk will have this number of events, whereas somebody with double risk will have these number of events. FGF23 is another marker which has been discovered. It's a serum measurement which has been discovered to determine, it actually goes up quite early in renal disease. Other people have devised ways of looking at the eyes and looking at hypertensive retinopathy or pre-retinal hemorrhage, and so developed ways to do that. And then measuring the stiffening of blood vessels directly correlates with kidney function. I'll just mention briefly our new efforts in chronic kidney disease. We are now conducting, or will be conducting in the next few months, pilot trials testing generic drugs. Obviously, the NIDDK can't afford to test up-and-coming drugs that the companies can make millions of dollars with. But basically, these are generic drugs to control phosphorus and FGF23, and see if that, on top of what's called ACE inhibitors and our traditional medications that we've used for the last 15 years, will slow down the progression of kidney disease. We'll give bicarbonate to decrease acid and inflammation. That's another trial which is just taking off now. and actually a new exciting trial, which is really coming in at the base level. We're going to use a prebiotic to improve the colonic microbiome. In addition to that, we are just starting a Cure GN addressing, it's an observational cohort of glomerular diseases, 4 different types of glomerular disease. We'll be recruiting 2,400 patients of all races and ethnicities. We are going to look at biomarkers, pathology, genetics, and clinical course of these patients over time. We anticipate that this will probably go on for another 20 years or so. And then we are anticipating, once we get that cohort of 2,400 patients, this will be attractive to the drug industry, who will join us and in selected diseases with new drugs and test these drugs in this cohort. So the NIDDK, and this is just to summarize, basically we're trying to enhance knowledge and improve outcomes. We do it through basic translation and translational research, clinical trials, epidemiology such as the USRDS, and longitudinal and clinical observations such as the Cure GN cohort. Basically, the USRDS is, as I presented, a tremendous amount of information. The CRIC and CKID have shown us different markers, and they continue these patients continue to be followed. We have the Glomerular Disease Network, which is just starting up. We have the CKD biomarkers, which is continuing to try to investigate different ways of early detection so that we can stop this progression in its tracks. And then we have actually a large basic portfolio of regular research grants, GoodMap, and we'll just be starting up this next year a fibrosis consortium. So, and then basically our CKD clinical trial network, and one of the ones that I didn't mention was a test in type 1 diabetes patients of allopurinol. So with that, I'm going to just stop talking, and hopefully I'm on time. Great. But anyway, I want to thank you for your attention.
Thank you so much, Dr. Flessner. Our next presenter for the session is Dana Mendenhall, who is the Director of Marketing for Baxter Healthcare. She has over a decade of health industry experience. Ms. Mendenhall's presentation today is to discuss the results of an important market assessment conducted among African Americans to assess the challenges that need to be overcome to better address and educate end-stage renal disease for patients, as well as peritoneal dialysis. With that, please join me in welcoming Ms. Mendenhall.
Good morning.
Good morning.
To Dr. Puckrin, Congresswoman Christensen, on behalf of the entire Baxter Healthcare Organization, we thank you for this opportunity to share our efforts. It was last year, this exact time, that Dr. Puckrin stood before an audience at Baxter Healthcare in Chicago and challenged us to address the healthcare disparity that exists with African American patients as it relates to peritoneal dialysis. Baxter accepted that challenge, and in partnership with Ipsos, a market research firm, we began to tackle this disparity. And we started with a dialogue to understand the journey of the African American dialysis patient. We began by looking at the 3 options, and currently, peritoneal dialysis is the second most underrepresented therapy at about 9.4% national penetration. Relative to this percentage, African American patients almost under-indexed by 3 percentage points, therefore not taking advantage of both the clinical and quality of life benefits that could be accompanied with peritoneal dialysis. Baxter wanted to challenge this disparity, and we began tackling this disparity by understanding and having a deep conversation with African American end-stage renal disease patients. Our market assessment had 5 objectives. Very quickly, first, to deeply understand the journey of the African American renal patient. Secondly, to explore the unique experiences, barriers, and challenges that they confront along this journey. Thirdly, to ascertain who are the key influencers and what role do they play in this journey. Fourth, we wanted to establish a hypothesis about African American segmentation. Contrary to popular belief, this is not a monolithic culture, and many segments exist here. And then fifth, we wanted to identify key go-to-market strategies that will help drive greater adoption for African American dialysis patients with peritoneal dialysis therapy. So very quickly, we had rich dialogue with about 60 participants. As you will see on the screen, we used many interview techniques to get at the heart of many of the issues and barriers for peritoneal dialysis. In addition to the number of participants that you see on this screen, we also spoke to congressional leaders and also community leaders in the states of DC, Illinois, California, and also Georgia. As we dug deep into the market assessment, we first uncovered that there are 2 journeys that are alive and present as it relates to the African American dialysis patient. The first is the ideal patient journey. This is a journey where the patient is concerned about, seeks active medical attention, and pays attention to the symptoms that his or her body is telling them. These patients are easiest to treat when referred to by nephrologists. They comply and work in partnership with their clinical team, and they educate themselves to make better choices about their decision options, sometimes months or even a year in advance. It is important to note that the ideal patient can become a crash patient at any point during his or her journey. The crash patient, you ask, is a patient who is unaware or quite frankly in denial about his or her symptoms. They avoid medical treatment at all costs and do not take action until their body tells them to do so. They have several comorbidities. They lack little discipline, and the theme that we heard earlier, no accountability for their health status. Quite frankly, as we heard these patients stated, until my body takes me down, I will not seek treatment. The context of the crash patient makes it very difficult for them to be viewed as an ideal PD patient who can start therapy, because there is a lot of preparation that is required for this therapy. And unfortunately for the crash patient, the first time that he or she is having a conversation about their diagnosis or initial treatment is in the emergency room, where sustaining life is the primary goal. So although there were a number of findings that we uncovered in this research, for time purposes and also for being relative to the topic here, I'm going to focus on those that are most relevant to the African American community that we spoke with in those 4 states. The first insight is that nephrologists use SCS, or socioeconomic status, to determine which patients are right for PD. They look at things such as insurance, race. They look at the quality of questions that they ask at this most vulnerable period. This is the diagnosis period. They inquire about the living situation. Is it a 1-bedroom apartment with 5 individuals, or is it a 5-bedroom home with 2 individuals living there? And then they also judge their aptitude by the physical faculties, again, that are displayed during this most vulnerable period of time. Nephrologists do not perceive any clinical difference between in-center hemodialysis and peritoneal dialysis. Therefore, they defer to these socioeconomic factors. And the problem that exists with that assessment is that African Americans then become disproportionately pushed into in-center hemodialysis, and that is exactly where they disproportionately fall in the SCS. The second insight that we uncovered was that patients fear that the lifestyle benefits of PD, the ability to work, the ability to travel, could make them ineligible for their disability benefits. They believe that if they adopt PD, they will automatically be sent back to work, and despite what their current health status could be, they'll lose those disability benefits. So therefore, they would rather not lose that disability when faced with the option to trial peritoneal dialysis. The third insight that we saw is that the mistrust of the healthcare system, and we know that this is not limited to just dialysis patients, but to African Americans across many disease states, especially that mistrust of physicians when they are uncomfortable around their initial diagnosis, and treatment path. And what happens here is they begin to self-diagnose. I've been guilty of it myself. We refer to websites, we refer to online research, chat rooms, blogs, neighbors, any other resource that we feel comfortable with and are close to build our knowledge about, in this case, end-stage renal disease and then the chronic kidney disease. And the challenge here is this information is often inaccurate and it's incorrect, and therefore patients are not being armed with the right information to make a conformed consent. The next insight that we uncover with patients is that they are made aware of their peritoneal dialysis option through the nephrologist or the nurse. However, they decide to stay in center due to non-medical recommendations at the clinic. And the challenge with this insight is that when a patient in center encounters another patient who's had an experience with peritoneal dialysis, the pool is already tainted. That patient who trialed peritoneal dialysis is back in the clinic for a reason. His or her experience was not positive. It was not successful. If it were, they would not be back in the clinic. So they're receiving limited, again, information that is often inaccurate. And the challenge here is that the patient who is considering peritoneal dialysis as an option is receiving testimonials from other patients or technicians, and these individuals have the power to enable or currently in most cases to impede peritoneal dialysis adoption. The fifth insight is that the longer patients are in center hemodialysis environment, the less likely they are to other treatment options. Logical, again, we all as humans resist change. The patients in this environment get comfortable, they create a routine and even a social network. So that sense of security, that sense of confidence, and quite frankly, being normal around other people who are experiencing the same journey that I'm experiencing becomes very, very hard to break. Again, the longer that the patient is in this environment, the more likely they will be to not evaluate peritoneal dialysis therapy as an option. And lastly, the sixth insight that we'll talk about today is the stigma that was associated with our conversations with these patients, the stigma that makes it difficult to talk about end-stage renal disease and even the early symptoms of chronic kidney disease with family and friends that are closest to these patients. They have a fear of their loved ones pulling away, being thought of as weak or being a burden or dependent on others, inconveniencing family members and friends. And these restrictions that their current dialysis regimen placed upon them make them believe that they're less fun, quite frankly. You know, these perceptions and stigmas create a stone wall in relation to the conversation that needs to be had about end-stage renal disease. And quite frankly, it denies the patient the support system that he or she could be benefiting from family and friends when these conversations are not happening. So in addition to these 6 insights, we also uncovered 5 barriers that I will go through very quickly that actually prevent peritoneal dialysis. The first barrier is, again, the horror stories about PD in the clinic where patients are hearing and being asked to think about peritoneal dialysis. These rumors about infection and death are heightened and they're left unaddressed. Again, these failed experiences only talk about one side of the coin. It is very important that these patients hear the other side, and the longer that the patient is in center and these rumors are left unaddressed, the more likely they are not to trial peritoneal dialysis therapy. The second barrier to PD adoption relates to the nephrologist and his or her not typically being supportive of this therapy for crash patients. And unfortunately, many African Americans are crash patients. Again, their diagnosis and initial treatment happens at the point of them arriving at the ER. When possible, nephrologists will try to push that crash patient to the in-center environment. Their thought process goes a little bit like this. They express that if I cannot count on a patient to take his or her hypertension meds, if I cannot count on them to monitor their blood sugar, why would I at this very crucial point give them or place a decision in their hand to perform dialysis in their home environment? Again, crash patients send these unspoken signals to nephrologists. If I am not compliant with my other chronic kidney disease regimen, how am I going to be compliant with peritoneal dialysis? The third barrier to adoption is that caregivers believe that patients do not have the discipline for PD nor the commitment to follow through, and that they worry it will result in more work for them and also potentially more health issues for their patients. They actually view in-center as their partner, so 3 to 4 times a week for 3 to 4 hours each time their patient goes to the clinic is quite frankly a rest period for them. They look at PD as a threat. It's not a partner. It's a very difficult and complicated therapy that their patient cannot do, and because of the perceived risk, they are adamant against not trialing peritoneal dialysis and being supportive of that trial for their patients. The fourth barrier that we uncovered is a barrier that I had the opportunity to experience firsthand, and it is that nephrologists and nurses believe that body image is a greater barrier for African Americans than for any other ethnicity. Prior to kicking off this research, I had an opportunity to go down to a DaVita clinic in the south side of Chicago with my colleague who's here with me today, and we were doing PD awareness days where we did education around PD. So I was there and talking to all of the patients and approached a gentleman and began to talk to him about PD, and he immediately stepped back from me like I had the plague, and I thought, well, what's going on here? And he said, I don't want to talk about that PD. It won't allow me to do what I need to do when I need to do it. So being the Southern woman that I am, I inquired, well, what is it that you do that you need to do when you do it? So my colleague Reggie, perceiving that I was a little naive, kind of stepped in and curtailed the conversation for us. Well, Reggie, I want you to know I knew exactly what he was talking about. I just wanted him to tell me. And what he was talking about was the barrier that the catheter presents. Patients already experience that having dialysis is somewhat of a downer, but now you impact my level of intimacy by having this tube extraneous to my body. So I don't want to have this. And when we talk to the men participants in research, they visually just shut down and won't even allow us to continue to talk about the benefits that could be achieved from, again, adopting a peritoneal dialysis therapy. The fifth barrier was around nurses not being supportive, as I spoke about earlier, of patients adopting PD therapy, again, because of their lack of commitment and the perception that it was a difficult therapy that brings too many complications to these patients. So they don't recommend it. They don't believe in it. They don't recommend it. So I've talked a little bit about insights, and insights for the sake of insight or data for the sake of data is, it's useless. Baxter is currently exploring opportunity platforms, and we want these opportunity platforms to really positively impact the disparity that African American PD patients are facing. These opportunity platforms are in 3 areas: education, eradicating the stigma, and also system change. Education for nephrologists and nurses that help them embrace not only the quality of life, but the clinical benefits of peritoneal dialysis. Education that is accurate and actionable for patients so that they can make conformed consents. Caregivers and patients and technicians, we want to bring them in so that they have a balanced conversation about peritoneal dialysis therapy. And then eradicating the stigma. We want to create a movement that actually changes both public and patient perception about chronic kidney disease and end-stage renal disease. We want to be today and start to create that same momentum that the HIV community had in the late 90s and has transformed all the way to today. We want to offer people hope for a normal life, a life that's around being a survivor and being a hero. And then lastly, the system change. We want to evaluate the merits of a PD first option as we look at the full continuum of care for a dialysis patient. We want to encourage nephrology, cultural sensitivity, and know that the same treatment path for African Americans from that diagnosis and initial conversation point may be very different for an African American when compared to a non-African American. And lastly, we want to increase credibility around PD messaging. We want to hear some positive PD stories that counteract some of those negative experiences and create African American ambassadors to help us drive these initiatives. So as you can see at Baxter, we are really, really busy and we are very committed to positively impacting this disparity that exists within the African American community. We welcome the opportunity with the National Minority Quality Forum to come back next year and to share the results that we expect to attain over the next 12 months. Thank you.
Our last presenter for the session on racial disparities in chronic kidney disease and diabetes is Dr. Enrique Caballero, who is the director of the Latino Diabetes Initiative and the director of International Professional Education. He is assistant professor of medicine at Harvard. He is also the founder of the Joslin Latino Diabetes Initiative that was launched in the summer of 2002. And it integrates culturally oriented activities in the areas of patient care and education, community outreach, and research. It is with great pleasure that I present to you Dr. Caballero, who will focus his presentation today on diabetes in the Latino population, as well as the basis of education and outreach activities. Please join me in welcoming him. Thank you.
Thank you. Good morning, everyone. I really want to thank the National Minority Equality Forum, Dr. Gary Puckrein, and Bill Griffith and the organizers for inviting me to participate in this activity and to be part of this great panel this morning. I always enjoy being in this type of activities. And what I will do in the next few minutes is to share with you some of the highlights about how diabetes affects the Hispanic population. But a lot of the things that you will hear are also applicable to other underserved populations like the African American and other groups. And I would start by saying that according to the most recent census, the Latino or Hispanic population is now considered the largest minority group in the country, represent about 16% of the total US population. Many of you know already that type 2 diabetes is more common in minority populations. According to some of the data from the SOLT study that Dr. Flessner already talked about, it's twice as high in the Latino population compared to the white population. And there are more complications as well. Unfortunately, there's worse glycemic control, there's more kidney disease, there's more retinopathy, there's more heart disease, and unfortunately many of the complications are more common in this population. As I will show you, there are clearly some social and cultural barriers to diabetes care, and many of which contribute also to the development of type 2 diabetes. Unfortunately, I would say there's limited awareness among healthcare providers in the country about what we need to do differently to help these populations, and I will give you some examples of that. And one of the common challenges is that physicians are very busy. There's limited time, there's no resources, there's no information. So what can we do about that? And I will show you some of the things that I think we can improve. And there are limited programs overall in the country that are addressing some of these disparities. I will start by saying that when we talk about the Latino or Hispanic population, we need to remember that this is a very heterogeneous group. Sometimes we put all Latinos together in one bag. We sometimes refer to Latinos as people that, we like to eat rice and beans and dance salsa. Well, that may be true in most cases, but not entirely. And what are the differences? For instance, even though Spanish is 99% the same, the way in which we refer to some foods is entirely different. For example, I'm originally from Mexico. I would refer to a banana as plátano. If someone is from Puerto Rico, would say guineo. If someone is from Venezuela, would say cambur. Very different words for the same thing. So you may speak the language, but that doesn't mean that you may understand what people are talking about. So that makes it even more difficult to address some of the educational challenges. And there may be also some genetic differences. In general, the higher the percentage of Black and Native Indian genes in any Latino or Hispanic population, the higher the rate for type 2 diabetes. And that's what happens with the Puerto Rican, with the Dominican population, for example. Now, the Institute of Medicine has shown that unfortunately there is healthcare disparities, and that applies also to the field of diabetes. And where are these problems? So there may be some biological issues. You here see in this slide all the players that we now have to explain the pathophysiology of type 2 diabetes. And I would say that in some of the minority populations, now we know that muscle does not respond very well to insulin. This is what we call insulin resistance, and this is more common among Latinos, African Americans. The fat distribution, the predominance of fat or intra-abdominal fat is also more common in African Americans and Latinos. So some of the examples of how type 2 diabetes may also have an explanation from the biological perspective, and beta cells, which produce insulin, may get tired more frequently in some of these populations. So there are some explanations that go that way. And as you already heard by Dr. Flessner, CKD, chronic kidney disease, is more common in African Americans and Latinos, and I would extend that to other complications like retinopathy, leg amputations, stroke, etc., that are more common in these populations as well. Now, overall, I think we have improved the care that we are giving to patients with diabetes. What you see here are the data from the National Health and Nutrition Examination Survey at different points in time, and you can see that gradually there are more people that have achieved an A1C under 7%, which is in general what we want in most patients with diabetes. But notice that that improvement is mostly in the white population. We haven't really achieved the same goals in African Americans and in Hispanics. And this is a very important element that we need to consider as we move forward. Why is it that we're not doing things that well? Here's another example. A1C, which as you well know is how we measure whether someone is well controlled in their diabetes or not, is usually higher in Blacks and in Hispanics in comparison to the white population. Now you see here a difference of about 0.8, 0.9% in A1C levels. That, according to some studies, may represent a difference of about 20 to 25% in the risk of complications. So it's not a trivial difference. It is really a very important difference that we may recognize. Now, you already heard also that children are being affected from complications. This is a study that we did a few years ago because I wanted to identify how early people are developing problems in metabolism and also in their vascular function. So to that end, we included a group that you see there called at risk. These are children and adolescents who are overweight. And that was people with BMI above the 85th percentile for their age and gender in comparison to healthy kids in their 50th percentile for body weight. And you can see that those at risk have more fat, according to some DEXA scans that we did, twice as much fat in their body, in their trunk, in comparison to the healthy kids. Now, all these are children that are overweight. They don't have diabetes, they don't have hypertension, they don't have cholesterol problems. they're just overweight. And what we saw was that when we compared how they were functioning in their pancreas and their insulin activity, you see in panel A that their blood sugars are exactly the same in both groups. That means they have normal blood sugars, no diabetes, no pre-diabetes. But as you can see on the right-hand side, they are already producing more insulin to compensate for that insulin resistance. So that is consistent with what we know in obesity. The pancreas compensates by producing more insulin. But the shocking finding, unfortunately, in our study was that when we measure different markers of vascular function, 7 of the 9 markers were completely abnormal in these overweight children. This is representing vascular inflammation. So these are the kids that are not only at risk for type 2 diabetes, but also for cardiovascular disease. Now we see people with a heart attack at the age of 35, 40, something that we never saw before. Well, this just establishes the fact that this starts very early in life, so we need to really implement prevention strategies to help our communities to really develop all these problems. Now, we are doing things late, and this is another point of illustration. This is a study that we published last year with Dr. Gary Puckrein and the National Minority Equality Forum, where we looked at the database of Medicare consumers in the country. So these are obviously millions of different people, and we classify them from those that cost the most amount of money, as you see there, called crisis consumers, to all the way those that don't cost that much money to the system. And this is a lot of data, but I just want to call your attention to, even though that we did this in different years, so this is 2000, this is 2006 as an example. If we look at the 10% of those people that cost the most amount of money, represented by these 2 initial lines, they take about 75% of all the money that is available in the Medicare system. Only 10% of patients with diabetes. And why is that? Because these are the people that are hospitalized, these are the people that go through dialysis, they have heart disease surgeries, they have amputations, they have blindness and all that. So basically what I'm trying to say here is that we're doing things very late. So people migrate to the upper categories. It's not always the same individuals. So the call for action is, why do we have to wait until people have the complications? Let's do things earlier when they are more stable, to keep them away from the hospital, to prevent the development of complications. Otherwise, we will continue to invest and use the money in the wrong way. And I think that a lot of what we're seeing here happening now with the healthcare reform, et cetera, I think is really going to help to move things in that direction. So let me just finish in the last part, just telling you a little bit about what we have done at the Joslin Diabetes Center. Some of you may be familiar with our center. It is considered a leader in the world in the fight against diabetes. It's been around for 116 years now. We're affiliated with Harvard Medical School in Boston. And I joined the Joslin about 20 years ago almost. And I was, obviously I've always been very privileged to work in this institution, but I was somehow shocked by the fact that we were not providing care to Latinos and African Americans when I joined the institution. And I took as a personal mission to try to open the doors of our institution to minority populations who suffer from diabetes and complications at a much higher level. And we have really seen a significant change in our institution. Now we have the Latino Diabetes Initiative, we're starting an African American initiative, we have an Asian initiative, and that has really helped us understand and help minority populations more effectively. So the Latino Initiative is a comprehensive program that integrates different activities, and we have a clinical care program, we have I'm trying to advance the slide here, I'm sorry. Can you advance the slide? Thank you. Okay, great, thanks. So we have a clinical program, we have a research program that are interconnected, but then what I will tell you is that I strongly believe that even though we can have a great program in-house waiting for people to come to see us, the way to go is really to go out to the community and really help people through education and outreach activities. And all that, that's what we put together in many of the professional educational activities that we develop at Joslin to help healthcare professionals nationally and internationally in the fight against diabetes. And we always recognize that there are healthcare disparities that are going on, and that I always think that it's important to remember that these are at different levels, the patient, the provider, and the system levels. And all these need to be addressed in order to really modify what is going on in the field of diabetes. We also believe that we should not look at the individual only, but we should consider that the individual is part of a larger group. Everyone has a family, everyone has a culture, everyone belongs to a society, and unless we incorporate some of these elements in what we do on the day-to-day activities, we will not be able to really do the best that we can. And there is a big list, I would say, of different factors that influence diabetes care. This is something that I put together in alphabetical order, not in any order of importance, but I'll give you some examples. For instance, acculturation. There's data that show that the more acculturated someone is in this country, the higher the risk for diabetes and hypertension, etc. In fact, the SALT study recently reported that speaking English, for instance, is a sign of a prediction for more diabetes and hypertension. So I'm going to turn now to Spanish to protect myself from developing diabetes. No, but what that means that unfortunately when people migrate to this country, many, of course, adapt unhealthy lifestyles. Of course, that's not the only option, but we need to educate ourselves about what we can do better, obviously, in order to improve that. Depression, for instance, is very common. It's the most frequently missed diagnosis in clinical practice. The education level is very important as well. Health literacy has become a very important element to evaluate in clinical practice, something that is not done routinely by many physicians. There's a lot of different myths and misconceptions. We already heard from Dana a lot of these things that patients express, and I would say that a lot of that is also part of what the Latino population represents. I'll tell you very quickly that there was a patient that was referred to me several years ago by a physician who didn't speak any Spanish. My patient didn't speak any English, and he was with out of control diabetes. The A1C was 11-12% for many years. And the note, I still remember, said, patient with severe insulin resistance and is not responding to treatment. So my first question to my patient was, well, are you taking your insulin? To which he said, of course not, claro que no. And I said, why not? And he said, because I don't want to get blind from taking insulin. And that never came across in the conversation with the provider. The provider was not aware that a lot of people believe that insulin can cause blindness and complications. Unfortunately, the patient was out of control. He had advanced complications. He died in the next 24 months despite trying to improve his diabetes care. So there's a lot of misconceptions that we need to really recognize in the community, and there's a lot of issues. Now here's an example of language barriers also that we try to address all the time. And believe me, this is a true story. This is a woman that received a prescription for a medication for hypertension, and it was signed as lisinopril 10 milligrams once/D. And the patient was rushed to the emergency room due to severe hypertension. Does anyone know what happened here? Well, she doesn't speak English, so she read the prescription and said, once is 11 in Spanish. So she took 11 tablets of the medication. She could have died, of course. Fortunately, that was not what happened, but this is, number one, not the right way to write a prescription. And we need to use, of course, the pharmacy services and interpreters and be sure. Now, one thing that I do with all my patients before they leave the office is to have them teach me back what they're going to do so that those mistakes do not happen. We have created some novel ideas about educating our patients. We have 2 audio novellas that we have developed. This is Rosa's story, which is the story of a woman with diabetes, and she shares all the challenges that she's had in the field of diabetes. And she talks about medications, about diet, about exercise. There's a physician, there's a nurse, there's a dietitian that participate. This has been a very nice way to educate our patients. And now we have Jose, who is someone with more advanced disease, and he has chronic kidney disease and heart disease and erectile dysfunction and all the problems that many patients may have. So in this case, unfortunately, the man is at a worse condition than the woman, but I guess that's all right. And these have been very well good ways to help our patients. Now, here's another example of sometimes we just try to translate materials, but they don't go in the right way. For instance, you're all familiar with this movie, Friday the 13th. If I ask anyone, how would you translate that into Spanish in case you want to roll this movie out in the community? The answer would be, how do you say Friday? viernes 13. Okay, so that's what you would do, but I would say, no, that's not the correct way. There's no Friday the 13th in Latin America. It's Tuesday the 13th, which has the same meaning. So a culturally appropriate translation would be Tuesday the 13th, martes 13, not Friday. So you may speak the language, but you may not know the cultural differences. So that adds to the challenge that we have all the time. And we need to engage patients more effectively in our conversations in our limited time. We don't know how to listen. This is really the criticism to us as healthcare providers. And as you can see here, very few patients really go and leave the office knowing what was assessed and discussed. We always recommend establishing some goal settings following the SMART acronym: specific, measurable, attainable, realistic, and with a specific time. Just saying, follow a better meal plan and exercise more, I'll see you next time, that means absolutely nothing to patients. So I think that we need to do that much better. We have now created group medical visits or shared medical appointments in which we have a group of people, and it's not a class, it's a medical visit. Of course, we follow the HIPAA regulations and confidentiality issues, but that has been another way to help this community, because as Latinos, we love to share our stories. There's actually no problem about people being shy of sharing their stories. Actually, sometimes we say that's not something that you need to say, actually, but I think that's a different level. And then let me show you that the last part is I think what is really very important, and that is about going out to the community and doing things. If we consider the amount of time that we can spend with patients in our practice, we cannot add more than probably one day, and I'm being very generous, in a full year when we have that communication with patients. So patients are in their community, they're by themselves, so we need to help them. Now, there are some challenges. This is a study that we did, and someone was, I think Dana, talking about body image as well, that in the white community, for instance, when we show this graph and we ask patients, which of these do you identify as the healthiest person or someone that you relate to? Most white women, we identify number 3 or 4, who are people with a normal body mass index. In our patients, the answer was 5 and 6, who are people who are clearly overweight. They have a BMI of probably 27, 28. So being thin is not a sign of good health in the Latino community. That may also happen in other communities as well. So we need to understand some of these cultural concepts in order to really improve what we do in the community. Now, when we give recommendations to patients and families, sometimes, as I said, we don't really go to the details that are necessary. So one study that we did with the Robert Wood Johnson Foundation was that we wanted to help patients. So my educators went to the supermarket with the families to teach them how to identify healthy foods without spending more money, which is always the complaint about eating healthier is always going to be more expensive. So this is an example of a family. As part of the study, we gave them $50 to go to the supermarket, and you can see there in the receipt, of course, you cannot read everything there, but that family with $50 bought 46,000 calories with $50. So after that, we did the education, we provided them with the Rosa story and other activities, the home visits, and after that, people were able in the family to really eat healthier, to buy better foods, improve their consumption of protein and reduce saturated fats, etc. And what does that mean? That sometimes we need to go beyond the usual in trying to help patients. Now we're looking at the next level. We can't go and visit every family, obviously, but what we're trying to do now is to probably use technology, cell phones. We're going to try to do something with the Verizon Foundation now about placing some monitors in patients' homes so that we can communicate in real time and provide education. And we can say that having a refrigerator that is half empty is not actually a bad issue, it's not a problem, it's something that we need to improve. So I would say that in closing, we need to integrate all these different activities, we need to guide the population, we need to negotiate models with the community so that we can implement strategies that work better, not only when people come to see us, but also when we go out to the community. And all that, I think, can help us in the fight against diabetes in the Latino population, in the African American group, and in many other communities. Thank you very much for your attention.
We would like to take this opportunity to offer the audience a chance to offer questions, ask questions, so that we can have some clear actionable items going forward. And so with the open of our Q&A, I just want to challenge our researchers briefly around solutions for the audience. So you have a lot of community stakeholders. So both Dr. Flessner and Dr. Caballero, if you could just comment briefly on how the audience in this room can help to take the research that you've presented and translate that out to the community level, either through communications or advocacy mobilization. How do we take the Jackson Heart Study and make it actionable for the audience? How do we take some of the research that you've presented, Dr. Caballero, and make it actionable for the audience at the real grassroots community level?
Well, can you hear me? Okay, yeah. I think that one of the ways that I've observed, and I've been at the NIDDK now almost 4 years, so I was a professor in the community in Jackson, and then before that in Rochester, New York. And what I've observed is that the squeaky wheel through Congress gets its way. So I would say that being aggressive about lobbying different members of Congress to fund the programs that mean something to you really can actually have significant results. We actually funded a program which was probably not our top priority, but was Congress's top priority, and it's been carried on at about 8 or 9 years. And so I think if you've got something with regard to kidney disease or with regard to diabetes, and of course diabetes and kidney disease actually are very, very highly linked, then get on the horn to your congressperson and lobby them about getting involved. I think that's actually what I see as bringing about change.
Yeah, I totally agree, and I would add that probably for everyone here in this room, the idea would be to pick a project, whatever you're working on, whether if it's a small or a large project, it doesn't matter, but I would emphasize, look at outcomes, try to get results, and those results, if you can tie those results with any financial or economical benefit, I think that then your voice is going to be heard, honestly, more effectively. Because as I showed you, we are spending so much money in the healthcare system in the complications of diabetes, that if we can demonstrate that prevention, education can help, not just for people to know more, but that translates into action that can reduce hospitalizations, complications, then we have a strong case to really present to everyone. And I think that way we can really get more funding and more support for any of the activities that we're trying to implement.
Terrific. And Ms. Mendenhall, if you could just address private public sector partnerships at the community level with the audience, if you could just briefly comment on how a community-based organization here can partner with the private sector to create some of the changes that you outlined.
Absolutely, and I think it's more about the private sector community and communicating and partnering with the community-based organizations. The first thing I would do is say the buzzword of the day is accountability. Hold private institutions such as Baxter accountable as we talk about our success, as we talk about being market leaders of peritoneal dialysis and, quite frankly, the largest provider of dialysis care. Hold us accountable and make us explain how those numbers play out across ethnicity when we're bragging about that, because I think that's where we'll begin to see a slightly different story. And then when we think about the platforms of education that have been provided today, the platforms of being culturally sensitive and knowing that what works for mainstream America may not have the same success in other ethnic markets. Hold us accountable to what we're doing to address the specific advocacy groups, community groups that you represent.
Fantastic, thank you. If there are we do have a question. Dr. Perez, there's a microphone on the side, Lucy, all the way over.
I appreciate that comment, especially coming from a pharmaceutical entity. And with the changes that have happened as it relates to the relationships that pharmaceutical entities and community-based entities and all the things that traditionally produce a tremendous barrier for the worker bees, the ones that are on the ground level, to get the type of funding necessary to be able to do this kind of street work, because that's what we're talking about. So the community-based organizations don't have what you would consider to be the fiscal accountability or track record. Yet they're indigenous to the community, they're trusted by the community, and they can't move forward. So when we, and this is important from a federal perspective, when we move to make sure that the entities that we know, i.e. what is the composition of their community advisory board, what is the composition of their board of trustees, you know, all of the things that we put in place to make sure that we get to play, when we do that, we're hit with an opposition. So now we have the three. I used to do work at the Jocelyn Center. Is that the same one that used to have the day camps? I mean, had the camps?
Mm-hmm. Yes.
And some of the issues, I would go as a doc with my children to the camp, and there might be one or two very brittle diabetics that were there because it was traditionally just type 1, and they could not get any services when they left camp. So we would work, get them to a point that they were better controlled, but all the things that we need didn't work. So my question is, with the three of you representing what we need indigenous in our community to do what we all believe needs to do, how can we empower NIH to do the right thing so that we can begin to see the true community participatory types of research that's going to make the difference?
Let's just go down the row and we'll just say like one succinct statement response from the three of you. Want to start, Dr. Caballero?
Well, I think that we need to show data. We need to show, as I said, that whatever we're doing is working. It's not just a nice program and that works for a year. We need to demonstrate that there's sustainability, that there's an impact, and as I said, there's some financial benefits. And I think the NIH is already supporting a lot of these activities. It's a very different world. Of course, the problem is that diabetes and all these conditions are advancing so quickly that we cannot keep up with that. But I think that some of these efforts are already in place. But I would insist outcomes at whatever level we can will help us with that cause.
Ms. Mendelsohn.
I would echo those points and just add twofold. I agree with you. The requirements to get the funding is becoming more and more restrictive, but the funding is still there. So we have to be very persistent around, again, targeting organizations, both private and non-private organizations for that. And it's really about that voice and asking the right questions. Again, as we celebrate our successes, as we celebrate this growth and this breakthrough, we have to ask the right questions. And we have to take that success and translate it to your particular, to my particular, to the particular community that we want to impact, and use our voice to demand that support.
Yeah, well, the NIH is supporting a lot of the research that I think you're speaking of. I think what another organization that directly impacts disparities is PCORI, the Patient-Centered Outcomes Research Institute. And they're currently funding about $500 million a year in very pragmatic type trials. And so I would encourage all of you to who are researchers to Google PCORI, P-C-O-R-I, and look at that website, because there are tremendous opportunities for people who want to study disparities in medical care.
Okay. I see your question. I know you have a question. In the interest of time, I am being flagged unless it's like a 30-second question, or else the panelists can be available at the base of the podium.
Very quick question. Thank you very much and appreciate it. Great work. The drug saxagliptin is going to be the premier gliptin medication on both the VA formulary and also the formulary for the Bureau of Native Americans in their affairs as well. It has an association with heart failure. Linagliptin goes off. Just a quick thought, should we be concerned with this heart failure issue with the saxagliptin?
Concern with saxagliptin and some complications from the medication? Mm-hmm. The DPP-4 inhibitors. Okay, so saxagliptin is a member of the DPP-4 inhibitor class. It's been, always linked to the possibility of pancreatitis, pancreatic cancer, all these different things. I would invite everybody to read the New England Journal of Medicine just a few weeks ago that did a wonderful review. This is the FDA and the EMA, which is the Association for the Study of Medicines in Europe. They have looked at all the data that is available with incretin-based therapies, GLP-1 analogs and DPP-4 inhibitors, and they have not found actually a connection with pancreatitis or pancreatic cancer. So I think this is truly the best evidence that we have at the present time.
Thank you. If there are additional questions, the panelists will be available immediately following the close of this session. Please join me in thanking our panel.